So diagnostic procedures are performed to really give us information. I recall back to my youth, G.I. Joe was knowing is half the battle. And so really it's important, it's probably more than that. It's important to know where your pain is coming from. So if a patient comes in and they have low back pain and leg pain, there can be multiple sources. It would be nice if it were just easy and that's the one location and we treat you with the injection and it goes away. But it doesn't always work like that. So in the beginning, and for something that's really important to us at RestorePDX is getting the right diagnosis. And so diagnostic injections are very precisely placed injections under image guidance with a combination of anesthetic, sometimes anesthetic alone, or a combination of anesthetic and a low-dose steroid or a dextrose injection. And we inject a particular tissue after talking to the patient, physical exam, imaging, that we think is the main bad actor. We treat that area and then we do a pain diary. The anesthetic works right away, so there should be, if we're in the right area, profound pain relief immediately. Unfortunately, the anesthetic only works for a few hours, so by dinner time that day, the pain may be back. There's no reason to fret at that point that the injection's not working, because there's a cocktail, right? So if that anesthetic wears off, then the steroid or the dextrose or a combination thereof may kick in, but it may take a few days, and that's the potentially therapeutic part. So we do the injection, you're taking that pain diary, and if we're in the right spot, fantastic, it's going to give you great pain relief. And then we're going to hope, we'll keep our fingers crossed, that the other medicines kick in, and then when we see you, traditionally around 2 weeks or so, for our follow-up visits, that you're still having wonderful pain control. So that's kind of the reason we do diagnostic injections. The other is, it may be an and, right? So it's not just that one area. So you may have back pain and leg pain, which could be a combination of a disc issue and facet arthritis. So it could be or hip issues or tendinopathy. And so even though we may treat one bad actor or actress and you have wonderful pain relief, that other area may still be painful. And we can separate those areas because one area will feel really good or some symptoms will go away, but some others may persist. And then possibly we'll even do a second injection into this potential second pain generator, and then maybe all the pain will go away. So there is sometimes a process, and we delineate that usually in our initial visits. So we'll talk to the patient, look at all the imaging, formulate a plan, and then we create what's called a differential diagnosis, meaning what are the different possibilities that are driving your pain. Sometimes it's really easy. A patient comes in, they have knee pain, and we know, boom, it's knee arthritis. Or a patient comes in, they have low back pain with leg symptoms, and it's more complicated, and it may take some workup. And so that's where the diagnostic injections come in and play a very important role. Well, we have a discussion. So number one, if the injection helped tremendously in an anesthetic phase, and it only worked for 4 hours, all the pain came back, then what that tells us is we're in the right spot. Because if there was fantastic pain relief for that very brief period of time, that indicates we're barking up the right tree. The problem is that the medicine that we've put in isn't strong enough or isn't the right medicine for that particular issue. And so then we have to walk through what are the different options. So now that we know body part X is the pain generator, what are the other treatments that we could do? Some of the time, and we're very passionate here about regenerative medicine if it's appropriate. So we look at that injury and say, is this something that's appropriate for regenerative medicine therapy? Or there are some other things that we can do as well, such as mild and 10X, and there's other procedures or even radiofrequency ablation. So we have a pretty nice toolbox of treating things, and it makes life a lot easier and our decision making a lot easier once we have our target. So jumping straight into a regenerative therapy is possible if the clinician is very comfortable with the diagnosis. So if somebody comes in and they've been worked up, they've had potentially some diagnostic injections elsewhere, or that the pathology is very, very evident. If somebody comes in and they have a plantar fasciitis, their heel hurts, and we look at it with ultrasound and they have a thick plantar fascia, there's calcium or partial tear, then it's that's one example of an obvious pathology. So we don't need a whole bunch of diagnostic injections or workup for that. There is a list of things that we could probably discuss that are very clear-cut. Patient comes in, they have knee pain, they have an x-ray, they have arthritis, we do an examination, everything fits with that, there's no mechanical issues. We know that pathway, we know what the treatment is, and someone can jump into a regenerative medicine therapy relatively quickly. When someone comes in with a complex spine issue, with low back pain or neck pain and pain radiating to the arm or shoulder, numbness, tingling, suddenly that becomes a much more complex issue, and we may want to discuss the appropriateness of jumping into a high-level regenerative medicine therapy. We hold ourselves very accountable to get our patients better, and we want to make sure that we're doing the right and prudent steps and not just jumping into something that may sound good, but that we may not have a solid foundation as far as diagnosis goes.